Good morning, everybody. Welcome to our first quarter CoreVantage webinar. Just quick introduction. My name is Beth. I am a dietitian, diabetes educator with Gem Care Wellness. So looking forward to our presentation here today. I have created my own little disclosure here. I apologize. I'm going to move my camera here a little bit. So this information that I'm going to provide for you today is a brief overview of diabetes medications. It's not exhaustive. It's a tool to help you understand the potential benefits for your health. It doesn't cover all the details about conditions, treatments, or medications for a specific person. It's not medical advice or an attempt to substitute for medical advice. You should contact your healthcare provider for personalized guidance on your own circumstances. The content doesn't endorse any certain treatments or, any specific medications. You want to talk to your healthcare provider. Again, in short, I'm not your doctor or your nurse, so I am your dietitian today, and diabetes educator, just trying to help you manage the diabetes a little bit better. So with all that being said, there is a Q&A. If you have any questions and you want to pop them in there, I will do my best to address them while we're talking. If I miss it, I will definitely try to get it at the end there for you. All right, with all that being said, I'm going to go ahead and get started. So just, kind of a quick overview of, diabetes medications and why they're used to treat diabetes, what the advantages and disadvantages of some of them, and just kind of helping you understand what the medications are doing and why we use them. Type 2 diabetes is very complicated. With type 1 diabetes, we kind of know, like, okay, the pancreas is not working. We have to give you some insulin to, get those blood sugars in good control. Type 2 diabetes is different pathways. I think I hear all the time, my friend's taking this and it's working for them, but, why am I on this? So just kind of those questions of why, what medications and what the thoughts behind using them that are. So just a quick physiology thought lessons here. With type 2 diabetes, there's many changes. There's the pancreas is not producing enough insulin. There's a decrease in the beta cell function. The brain, you don't always feel full. There's a decrease in dopamine. Peripheral tissue, there is some of the hormones that aren't uptake, they don't uptake well and they're not used efficiently in the body. I always like to call it like a mechanical issue. They're just not mechanically, things are not going right. In the kidneys, there is an increased absorption of glucose or sugar back into the body there. So we're not getting rid of it as we should. In the GI tract, there is endocrine deficiencies and or resistance. So that's where the big medications like the GLP-1s that, a lot of us are talking about and hearing about now are working the most efficiently there. In adipose tissue or fat, there's some increased inflammatory mediators, there's increased free fatty acids that lead to inflammation, insulin resistance, increased blood pressure, dyslipidemia, or, kind of skewed cholesterol numbers, and often an increase in weight also there. So, again, in summary, type 2 diabetes is progressive metabolic disorder. It's characterized by abnormalities in the way we metabolize carbohydrates, fat, and protein that lead to a high blood sugar state. So in my perfect world, yes, we could do it all with diet and exercise, but it doesn't always happen that way. So again, those healthy lifestyle behaviors are the first piece of diabetes management. And if you look at the ADA or the American Diabetes Association guidelines, that's it, healthy, eating healthy, more exercise, that's where we want to start. But then, typically with type 2 diabetes, we do have to add that medication piece in. The 2025 guidelines for diabetes management actually focus on looking at cardiac and kidney risk with type 2 diabetes first before determining medications, just because some of these medications are so much better at preventing or stopping progress or slowing progress, I guess would be the better term, of kidney disease and heart disease. I think starting in about 2008, all diabetes medications had to show no cardiovascular harm. So that's why, we think about the benefits of the medications when even if they may not give the best change in blood sugar, sometimes the benefit of the medication outweighs the using something else to get better blood sugar control. With all that being said, kind of trying to get to the medication piece here, questions that you want to answer, ask yourself, or, that I would always kind of tell people to think about when we're doing that diabetes education part. How long have you had diabetes? When's your blood sugar too high? Is it before you eat, after you eat, or both? Different medications target different areas, and we'll kind of touch on those, kind of very briefly as we can here. How do you prefer to take your medication? Or do you want to take a pill? Do you want to have an injection? Are you open to using an injection? There is insulin that's inhalable. So, sometimes the initiation of insulin, somebody does not want to use an injection. So there is another option out there. How much do you need to decrease your A1C to reach goal? So that would be, when we're kind of looking at that overall blood sugar control, what do we, is that A1C at 9? And do we want to get it to 7? Is it more appropriate for you to have a little bit higher or lower A1C? Do you have any side effects or trouble taking medications? So you want to avoid, if there's medications that are bothering you, of course, there are other options out there. Do you have other health conditions? So this is where the heart disease, kidney disease, overweight, obesity, depression, any outlying condition beyond the diabetes, we want to think about those. And, some of these, like I said, some of these medications are going to help us manage numerous conditions all at one time. Lastly, is the treatment convenient for you? So when we talk about these medications, think about like how many times a day do you have to take it? Does it fit into your schedule? Do you work shift work? Do you, are you a mom of 6 kids and you don't have time to stop in the middle of the day, or you're on the road all the time? Kind of just thinking about those different factors that may influence the choices that you make. Just a brief review of the goals, like where you want your blood sugars to be. So one thing I think about with this, especially with the CoreVantage group, is, a lot of you have a continuous glucose monitor, which is, I have to admit, as a diabetes educator, one of my favorite things in the whole wide world to help manage diabetes. It helps us to look individually at, how certain foods affect you, how exercise, how stress management, how sleep, all of them, influence your blood sugars beyond, what the normal things that we think about. The goals are still the same. When I look at a continuous glucose monitor, time in range is the big buzzword there. So we're trying to get time in range, or that time that your blood sugar is between 70 and 180 at about 70% or more. On the flip side, blood sugars below 70 can be hazardous for some, so that, we want that time in range, or that time when blood sugars are below 70, to be very low, less than 4%. And just to kind of give you an indicator, 1% is 15 minutes. So we want to spend less than an hour with that blood sugar below 70, ideally. And, just one other thing with the continuous glucose monitor, there is some of the data that is not included there. So there's like 5 to 10% of the data that doesn't always show up on those reports. So, kind of thinking about that a little bit. But overall, the ADA, which is the American Diabetes Association, and the AACE, which is the American Association of Clinical Endocrinologists, have their goals. That the endocrinologists have a little bit tighter control that they're looking for usually. Normal fasting blood sugar below 100. If you are diabetic, between 80 and 130. The Endocrinologist Society likes to see that number below 110. If we're looking post-meal, that's like how your body is handling the carbohydrates and the digestion process. So normal would be under 140. ADA goal is under 2 hours after that meal that blood sugar is under 180, which if you think about the continuous glucose monitor, that keeps us in range. And then the ACE goal would be to keep that 2-hour meal blood sugar under 140. And A1C, typically we like to see it under 7 when somebody has been diagnosed with type 2 diabetes. An A1C of less than 5.7 is non-diabetes. It's 5.7 to 6.4 is typically pre-diabetes, so that shake on the shoulder to get things moving. An A1C of greater than 6.5 is typically diabetes there. So all that being said, we're going to kind of dive into the medications here now. When we talk about the meds, they're either going to affect your fasting blood sugar, your post-meal blood sugar. This is just kind of a little tidbit here of what is, kind of what is being influenced with, from inside your body here, your liver or your hepatic glucose output. So liver stores sugar as glycogen. Glycogen will break down into sugar when your blood sugars start to drop. The glucagon tends to be the piece that helps control that, that glucagon is released. So those regulatory systems can be kind of a little bit messed up with type 2 diabetes. The other thing with post-meal blood sugars, to think about is carbohydrate intake. So this is the lifestyle piece. If I eat too much, my blood sugars will tend to be too high. Also the gut absorption, how long is it sitting in the gut? Are there other conditions that are going on that are influencing that a little bit there? So just, kind of a little overview of what helps, what's going on when the blood sugars are too high when you're fasting versus post-meal. The medications. So some affect the fasting more, some affect post-meal blood sugars more, some do both. So when we talk about the meds, we'll kind of touch on that a little bit more in detail in respect of time here today. So the ones that affect the fasting the most, we're going to start with probably the most common, the biguanides or metformin, as it's affectionately known. I think, has been the first line of treatment for diabetes or type 2 diabetes for quite a few years now. How it works is it helps the liver not spew out so much sugar. It also, liver and muscle, it also helps with insulin resistance a little bit. And there's a slight, there's some slight advantage into the gut, slowing down sugar absorption in the gut there. What are the benefits or the advantages? It's affordable. It's weight neutral. There's even a little bit of weight loss with it in some cases. Very low risk of low blood sugars with it. It may help to reduce LDL, which is the lousy cholesterol, and triglycerides. So, maybe a slight bit of cardiac benefit there. The disadvantage, most people are going to complain about the gastrointestinal side effects. So AKA gas, diarrhea, constipation, bloating. Yeah. Theory is that the side effects go away within a few weeks. If they do not go away for you, do discuss with your healthcare provider what, is this the right treatment for you? Is it the right dosing? There is a short acting, there's extended release. Is the dosing too assertive? Do you need to back off on the dosing a little bit? Are you taking it with food? All the things that may make it more tolerable. And it often can be combined with other medications, which, we'll kind of touch on at the end there. So, metformin, been around, cheap, easy. If you go to the doctor today, the doctor writes you a script. You can go to the pharmacy. Even if you pay out of pocket, it is usually affordable there. All right. Our next group of medications here, they are not used as much as they used to be, but the thiazidinones, I always like to say it, I think, so affectionately known as the TZDs, they help with insulin sensitivity, increase insulin sensitivity. The two big players are Actos and the Avandia. Avandia is no longer frequently used. There has been association with a risk of heart attacks and cardiovascular death, and then bladder cancer was associated with an increased risk of bladder cancer with actose or pioglitazone. So we don't see these meds as much, but they're still there. I mean, they're still out there. They're still being used. It does have a significant lowering of cholesterol, like a half, or I'm sorry, of A1C, a half point to a point. You may, sometimes if these are on your medication list or you see them on someone else's medication list, they probably have been on them for a while. So that is the TZDs. The next one that we are going to talk about is basal insulin. So again, the pancreas doesn't spits out insulin all the time. So excuse me, sometimes with type 2 diabetes, especially that insulin isn't being released as it should. So this long-acting insulin, such as Lantus or Tresiba, there are others out there, last over the course of 24 hours. They're dosed once a day. They are, they kind of help with that, regulate blood sugar all day long, between meals, overnight. Sometimes if somebody has a high fasting blood sugar, or if we look on your continuous glucose monitor and blood sugars are consistently high, like you're not having lots of fluctuations after your meals, but it's just like always kind of running high. Sometimes that basal insulin can be the answer there. There is always something in the pipeline. There is a once a week long-acting insulin. It has not been approved by the FDA yet. So it, again, may make that treatment piece a little bit easier for somebody that would struggle with daily insulin dosing. All right. The next one is the one that everybody, I think, is the hot topic now, that's for sure, is the GLP-1 antagonists. So they are, they help with both fasting and postprandial blood sugars. They have cardiac and kidney benefits. Victoza, Trulicity, and Ozempic are the ones that are kind of, in all the long-term studies there. I like to call them smart medicine. They do lots of things. They kind of enhance the release of insulin when you eat. So they tend not to cause low blood sugars because the insulin release only happens when there's food present in the gut. They slow down digestion, so they tend to make you feel fuller longer. So kind of stays with you. It's that kind of that gut to brain relationship that is when it's a GLP-1 antagonist, it antagonizes the GLP-1 in the gut to work better, harder. So it, kind of works on that gut to brain relationship to help you feel fuller, longer, push back sooner. The treatments tend to be pretty easy. They're once a week injections. There is an oral option, which is the Rybelsus. So that Rybelsus is the oral version of Ozempic or the semaglutide. It's not a disadvantage. It's just a different use with Rybelsus. It's a daily pill. You are taking it every morning, fasting with about 4 ounces of water. You do have to wait about 30 to 60 minutes before you have anything else with it. So, or after it, that way the GLP-1 lives in the gut and is able to help those blood sugars. The highest dose, the progression is, I think it's 3 milligrams, 7 milligrams, and then 14 milligrams. Don't quote me on that, and not exactly, but 14 milligrams at this point is the highest. And it's equivalent to a half milligram weekly of the injectable semaglutide or the Ozempic. So you can't be quite as assertive with the treatment with the Rybelsus, but if it works, if it controls the blood sugar, that's the goal there. Its job is to help control blood sugar. So if you don't want an injection, the Rybelsus may be a good option. And I'm sure there will be more orals in the future as they learn how we can ingest them and have them work for us like we do the injection. So again, the advantages there are the kidney and the cardiovascular benefits. Consideration is how you use it. The disadvantages can be these side effects for some people, but again, they tend to be treatable, and we can learn the lifestyle piece to help, manage them a little bit better. But nausea, vomiting, diarrhea, constipation tend to be like I said, tend to be transient, so will tend to go away as we either eat better, take them a little bit differently, learn the timing of when to take them, get the dosing correct there. There are a few considerations, and again, these would be things you'd want to talk about with your doctor. If you've had a history or a risk of pancreatitis, they may not be the best choice there. We caution with gastroparesis. A history of gastroparesis doesn't rule them out, but they tend to be used a little bit less. Same thing with gallbladder disease. If there's a couple rare conditions. Everybody I'm sure has seen the commercial at this point in time. If you have a family history of medullary thyroid carcinoma, multiple endocrine neoplastic syndrome type 2, there's a couple conditions that warrant not using the GLP-1 antagonists. But they are, they are, if not a second line of treatment with the new ADA guidelines. Sometimes if metformin is not tolerated, they can be a first line treatment. The other, sometimes we lump these together, but I pulled it apart just because it's the GLP-1 and GIP antagonist. So we've got another hormone involved there, aka Mounjaro or tirzepatide. It, has, again, the same properties as the GLP-1s by themselves, but then we have this medication that has another hormone in there. So we're seeing even a little bit more weight loss with it. It, again, just like the GLP-1 alone, helps with both fasting and postprandial blood sugars. It's a once a week injection. It has shown cardiovascular benefits to, there's low risk of hyperglycemia or low blood sugars. The treatment's pretty easy, has a pretty assertive effect on the A1C, lowering it by 1.8 to 2.4%, in a relatively short period of time. Next medication are the ones that have the most impact on post-meal blood sugars. So remember the GLP-1s and the GLP-1 GIP, so aka Ozempic, Trulicity, Victoza, and the Mounjaro are the ones that are going to affect the postprandial and the fasting blood sugars the most. These also will influence the post-meal blood sugars a little bit more. And the group, the sulfonylureas, or anything that ends in IDE, if you look on your medications, the glimepiride, glyburide, glipizide, they are going to usually be taken with food. They kind of had this effect of, for lack of a better description, kind of squeezing the pancreas and getting the insulin out. So we take them, and then we will tend to see the insulin production happens, and then we'll see the blood sugars come down. So the disadvantage sometimes of the sulfonylureas is low blood sugar. So somebody takes it and doesn't eat, or don't eat as they planned, they risk having low blood sugars. Weight gain can be, there's sometimes with the use of the sulfonylureas, there is weight gain. Reduced efficacy over time, so they tend not to work as well over a long period of time. So that would be, after you've been on it for years, and sometimes that is attributed to the decrease in the amount of insulin that the pancreas is producing. With type 2 diabetes, there tends to be a decline. And we do caution the use with kidney disease. So again, there is, we don't have the cardiac and the kidney protection with the sulfonylureas. The advantages are they're inexpensive, they're readily available, they've been around for a long time, and they do have the potential to lower the blood sugar by about 20%. They have a very pronounced reduction in the A1C. So, again, they're affordable, they're around, they may cause hyperglycemia, and they do a good job of lowering the blood sugars there. The next group of medications to kind of think about is the DPP-4s. So you may know them as Januvia, Tradjenta. There's a couple other out there. There's Onglyza, Nasina. There probably are a couple more, but just, kind of this group, I like to call them the DPP-4s, kind of the early cousin of the GLP-1s. And that the reason being is they kind of have similar effects. They prolong the gut hormone action. They don't boost the GLP-1 hormone, but they inhibit the DPP-4 hormone, which can inhibit the GLP-1. So we get a little bit of that effect of delayed gastric emptying with the DPP-4s. They also boost insulin production, which is kind of the buzz with the diabetes treatment medication. We're trying to get the blood sugars down, so we may need a little bit more insulin. So when there's food present, we don't tend to see any low blood sugars with them, or very rarely do you see low blood sugar. There's no weight gain attributed to the medication, so that can be, if you are overweight or looking to maintain weight, that can be a kind of a good advantage there. It's oral dosing, there's no injection involved. They can be taken any time of the day. So, I mean, that can be a big one. It's not like you have to take it first thing in the morning. You can take it with your evening meal. You can, as long as having that discussion with your doctor, take it before bed. So if it's convenient, if you do work shift work, things like that, it's one that can be moved around throughout the day there. Some of the side effects are not pleasant. They, headache, flu-like symptoms, which again tend to go away. They do have a little bit higher cost than some of the medications there. The kind of the takeaway with the heart, the cardiac and kidney piece is there. Onglyza and Nasina are to be avoided with patients with heart failure, but Januvia and Tradjenta, which is the reason I didn't have room to put them all on here, but the reason I put the Januvia and the Tradjenta on here is because they tend to be safe with patients with heart failure. So again, thinking about these new guidelines, we want to be heart protective there. And then next up is this group. This tends to be these medications, the SGLT2 inhibitors, are right up there now with metformin and the GLP-1s. They are, again, if you watched a commercial on TV, you've probably seen Farxiga, Jardiance. There are a couple other ones, Invokana, Stiglatro, are the other two that I can think of off the top of my head. The way these work is they increase urinary glucose excretion, basically help you to urinate out sugar. They do have benefits of a little bit of weight loss. They can help with blood pressure control, so that fluid balance there. So again, they do have that cardiac and kidney protection. So if you are, if you're on a blood pressure medication, blood pressure still running a little bit high, starting an SGLT2, aka Farxiga or Jardiance or one of the others, can help with that blood pressure a little bit without adding on another blood pressure medication there. The other thing that anybody with a history of gout is they tend to decrease uric acid levels. So somebody with it have been shown to decrease the incidence of gout flare-ups. So that would be, again, gout, not a pleasant condition. If it's another chronic condition with diabetes, then, hey, maybe we get a little help from the SGLT2 to prevent the gout flare-ups. We get a little bit of help from the blood pressure. It protects the kidneys, and it also has some cardiac protection. And they do have, they have a decent lowering of the A1C, 0.5 to 1%. Disadvantage can be the urinary tract infections and yeast infections, which, they are treatable. there is some showing when blood sugars are higher, you see these more. Is it a good discussion always to have with your physician is if you are getting frequent UTIs and yeast infections, then maybe it isn't the best medication for you. But if you are getting like one a year, is it easier to treat that and continue on the medication because you are getting some other benefits from it? So again, just kind of one of those things we think about when we think about the diabetes medications. Next up, we have meglitides, which Prandin, Starlix, they are another one of these medications we don't see as much anymore. They have been around for a long time, like sulfonylureas, so glyburide, glipizide, any of the ides there, they help the pancreas stimulate insulin secretion. So they are going to help with that immediate blood sugar control there, and they're going to get that insulin out to help bring the blood sugars down. Always remembering that insulin is that catalyst that takes the sugar or the glucose to the cell, opens up the cell, lets the sugar in to produce energy, gets it out of the bloodstream. So that's what the meglitides do. They do not contain any sulfur, so anybody that has a sulfa allergy and cannot use a sulfonylurea can use either the Starlix or the Precos, or I'm sorry, the Prandin or the Starlix. So that can be a benefit there. They have some dosing flexibility, as to when you can take them. They tend to be more expensive. The disadvantages being more expensive than the sulfonylureas. They can cause low blood sugars. They can cause a little bit of weight gain. They are glucose dependent. So if if your blood sugars aren't high, they aren't really doing much for you. They have a rapid onset and a shorter duration. So again, for somebody that kind of forgets to take their medicine until they start to eat, this can be helpful. You take it, you can wait till right before you eat to take it, and it doesn't stay in the system very long. So it can help with that meal, help with that postprandial blood sugar, and then kind of move on from there. It's not causing any it's not staying in the system long term. It has a short half-life. This one, the alpha glucosidase inhibitor, so Precos and glycate, they've been around for a long time. Don't see them used very often, but you may see it on your medication list or your friend's medication list, or somebody that what they do is they slow absorption of glucose from the intestine into the bloodstream. So they large carbohydrates, they break it down into more absorbable sugars, so it takes them longer to absorb. So therefore, the absorption slower, so the rise in the blood sugar is slower. They have to be taken with each meal, so it's frequent dosing, so 3 times a day. So again, maybe not for that person that has a hard time remembering to take medications multiple times during the day. They do have some not fun side effects, gas, diarrhea, abdominal pain, bloating. They are weight neutral. They tend not to, have any influence on weight. With the onset of low carbohydrate diets, if you're eating a very low carbohydrate diet, this may not do much for you because remember, it slows the digestion of carbohydrates. So if I'm not eating very many carbohydrates, it's probably not going to do a whole lot for my blood sugars there. I only bring that up because it's another reason to really have that discussion with your physician as to what your diet looks like, what your lifestyle looks like, what is, kind of what's going on there. Last but not least is fast-acting insulin. So Novolog, Humalog are the biggies. Afrezza is the inhalable insulin. So some people don't even know it's out there. I unfortunately don't see it used very often. It's available in dosing cartridges. I believe it's like 6, 10, 14 units. Again, don't quote me on that, on the exact dosing strategy of the Afrezza, but it is, it's got to use for the people that have like high blood sugars after one meal, like if you or your like your lunch meal or your evening meal, or that person that's supposed to be using fast acting insulin with each meal, but you're at work and you don't want to get your insulin pen out, and or you're traveling or whatever, but the inhalable insulin can be a quick fix. It can be a quick introduction to, helping with one meal a day. If, when we look at those continuous glucose monitor reports, if your blood sugars are spiking after a certain meal and other medications are not working, maybe short-acting insulin is the answer there. Again, a discussion to have with your healthcare provider. But, insulin it's got it works great. It's going, if you take insulin, it's going to lower your blood sugars in 99.9% of the cases. Minimal side effects. If you have other conditions, the insulin is probably not going to interfere with that. I always think about if it can be used in pregnancy, it's probably safe for most things. So insulin can be used in pregnancy. Dosing, it's so easy to adjust the dosing of insulin based on kind of where the blood sugars are. We do have this inhalable option if we can see it used a little bit more. Disadvantages, of course, taking an injection can be a challenge. High risk of low blood sugars or hypoglycemia, so we always have to be prepared for that. Going to vary on. We can get, 99% of the time, you can get A1C within a normal limit without, with insulin. All right. I know I'm getting very close to the end of my time here, so I'm going to wrap through these last couple here. Just food, thoughts to help you make these medication decisions, to have a good discussion with your healthcare provider as to what is the right combination for you. Is it safe for you? If it caught, low blood sugars, if you're having problems, an adjustment or a different medication may be the answer there. Can you tolerate it? If you're taking metformin and you have to stay in the house all the time, it's not doing your lifestyle any good there. Performance, is it getting you to goal? Is it getting your A1C to where you want it to be? Pricing, of course, how is it covered by again, I cannot address all the pricing strategies. Sometimes the best option may not be affordable. So, is it are we getting the right price for the best price for what we can do? And simplicity, like how many, some of these medications can be combined. There's lots of, combination medications out there, like Januvia or Janumet is Januvia and metformin together. There's Synjardy, there's Qturn, there's lots of them that are combining some of these medications together. So if you're taking 3 pills now, you're taking 1, and you might be able to take it once a day using extended releases, things like that. Insulin dosing, can we use an inhalable instead? So just things to think about. It has to be doable for you. You can have a great plan, but if you're not doing it because your lifestyle interferes with it, then it's not going to work for you. Again, these are just some other takeaways for you. Look for medications with the fewest side effects, make it simple. Write down, make a list of side effects you're experiencing, issues you're having with your medications, the costs, keeping up with the doses. Are you happy? Are you getting, are you on the same thing for 10 years, and every time you go to the doctor, your A1C is creeping up a little bit, but it's like, okay, we're okay. We're going to just keep doing this. Would a change make a difference for you? Because we do have lots of options out there. The last few years have really brought numerous things to the table. So with all that being said, I am going to open up to questions I don't see anything in the Q&A here, but if anybody has anything, please let me know. All right. Well, with all that being said, I am, like I said, I am leaving it open. If anyone has any questions, we have a couple minutes here. Please feel free to pop them in there. There's any resources or anything that would be helpful for you. There is the, ask the RD at Gem Care Wellness. If you are with Edwards Healthcare Services, part of the CoreVantage program, I'm going to do a little plug for our services that we have. You have you're open to a quarterly call with a registered dietitian. If you have a Libre or a Dexcom, we can connect that data. We can talk through some of this, and kind of brainstorm through and see if there are any, options or things that would help you manage that diabetes piece any better.